our CPD for the evening and CPD for our yearly CPD, we also have to look at our spiritual CPD. So we invite also participants to have a look at the website www.mubz.co.za. It's boobs.co.za. Madrasa Urwa bin Zubair, and it also targets various health professionals. It's a very dynamic madrasa and something to look at. And without further ado, the nasiha from also the Qari Abdullah that will now be played by Dr.
السلام عليكم ورحمة الله وبركاته. أعوذ بالله من السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، وأفضل الصلاة وأتم التسليم على سيدنا محمد وعلى آله وصحبه أجمعين. أما بعد. In the name of Allah subhanahu wa ta'ala, the most gracious, the most merciful, our beloved Prophet Muhammad sallallahu alayhi wasallam has said, whoever removes a worldly grief from a believer, Allah will remove from him one of the griefs of the day of resurrection. And whoever alleviates the need of a needy person, Allah will alleviate his needs in this world and the after. Whoever shields, means or hides the misdeeds of a Muslim, Allah will shield him in this world and the after. And Allah will aid his slave so long as he aids his brother. Your sleepless nights, your unwavering support, your unmeasurable effort and your heroic sacrifices is something that will remain etched in my heart forever. Know that Allah subhanahu wa ta'ala has seen your days and your nights, and all this is recorded and will be recompensed. We, the humble servants of Allah subhanahu wa ta'ala, appreciate and are sincerely grateful for your efforts in taking care of the creation of Allah subhanahu wa ta'ala. In relation to today's topic on the aspect of fasting and diabetes, we can analyze three types of fasting. Allah subhanahu wa ta'ala says in the Quran, أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الذين آمنوا كتب عليكم الصيام كما كتب على الذين من قبلكم لعلكم تتقون أياما معدودات. That all you who believe, Allah subhanahu wa ta'ala mentions, all you who believe, fasting has been ordained upon you just as it had been ordained on those before you. What's the reason for us practicing on this act of fasting? لَعَلَّكُمْ تَتَّقُونَ, so that we may draw closeness to Allah subhanahu wa ta'ala, and this is prescribed for a number of days, in specific the month of Ramadan. So the obligation of fasting during the month of Ramadan is incumbent on every matured male and female who is sane. A person who is unable to fulfill any of the fasts during the month of Ramadan, it would necessitate an atonement after the month of Ramadan. The next category we can look at is fasting which is wajib, and this would be such that the person also is required to fulfill the fast. So this category relates to a person taking a vow with the name of Allah subhanahu wa ta'ala to fast on a specified date or after the achievement of a specified wish or desire. In this case as well, atonement would also be necessary if it is not fulfilled on its appointed due. The third case is the type of fasting which is noted or referred to as voluntary fast. A person will be rewarded for fulfilling a voluntary fast. However, no fault will be on the person if he does not fast. Nabi sallallahu alayhi wasallam has mentioned in a hadith wherein Nabi sallallahu alayhi wasallam has stated, it is sufficient for you to fast 3 days every month, because for every good deed you will have the reward of 10 like it. So that will be like fasting for a lifetime. So this is a reward for a person who endeavors to keep these voluntary fasts, and in return the reward will be as if he had fasted for his entire lifetime. Why? For every year, it will be considered to be, in terms of the lunar calculation, 360 days of fasting, the reward given of 360 days. So that is the entire year. So the reward of a lifetime will be gifted to this person for fasting in the month of Ramadan, or for fasting these voluntary fast, referring to the 3 days of every month. We also note then that in fasting there are indeed numerous benefits. Just to mention a few, that one is it enhances our bond with Allah subhanahu wa ta'ala, that our connection with Allah subhanahu wa ta'ala is strengthened. Another is it teaches us discipline, that in abstaining from food and drink and intimate relations with our spouse, in this way we are able to use and implement this in our daily lives as well. Fasting also improves blood sugar control, it reduces inflammation, it assists in weight loss and improved brain function. Fasting also helps to suppress the carnal desires. These are just a few, but there are many other benefits as well. You, as the medical experts, would indeed appreciate these benefits, and most certainly you are better versed in this particular study than us. Indeed, the reward for any effort in fulfilling the command of Allah subhanahu wa ta'ala is great. Allah subhanahu wa ta'ala also mentions in the Quran that Allah doesn't place on a soul except what is within his capability. Allah doesn't place on a soul except what is within his capability. Therefore, in terms of the principles of Sharia, there are some leeway which is gifted to a person. Based on the difficulty, the person will be rewarded immensely. We can say the harder the input, the greater the output. We can understand this from the various ahadith of Nabi Sallallahu Alaihi Wasallam. So just to mention a few, Aisha radiallahu anha has reported, we have said, that the Prophet Sallallahu Alaihi Wasallam has said, verily the one who recites the Quran beautifully, smoothly and precisely, he will be in the company of the noble and obedient angels. And as for the one who recites with difficulty, stammering or stumbling through its verses, then he will have twice that reward. Another hadith narrated by Abu Hurairah radiallahu anhu, the Prophet ﷺ has said, shall I not tell you something by which Allah effaces the sins and elevates the ranks in Jannah? The companions asked and said, yes, O Messenger of Allah. He said, performing the wudu properly in spite of difficult circumstances, working with more paces to the mosque, to the masjid, and waiting for the next salah after observing a salah. O kama qala alayhi salatu wasalam. So these are two benefits, or the reward being greater for the effort placed in an action to be done, which Allah subhanahu wa ta'ala will give us. Another ahadith we can also note, which Nabi Sallallahu Alaihi Wasallam has mentioned, that whoever among you can marry should marry, because it helps him lower his gaze and guard his modesty. And whoever is not able to marry, he should fast, as fasting diminishes the carnal desires of the person. And a person, we also know, in lowering the gazes, a person is able to attain the sweetness of Iman. That in doing so, it is challenging, but the reward is indeed great. Why? We will achieve the sweetness of Iman. In situations whereby we look at the context of a person suffering from diabetes, that a patient who suffers from diabetes, and if a pious Muslim competent doctor advises him that fasting will be harmful to his well-being and will affect his treatment and counseling, then such a patient will be allowed to atone the must fast of Ramadan at the time when he is fully fit to do so. The second case we can also note, referring to a patient suffering from diabetes, is if a pious Muslim competent doctor gives the advice that the patient's well-being will worsen from fasting, then the patient will be excused from fasting, and the patient will be required to discharge the fidya, known as a monetary compensation, instead of fasting. So long as the patient's conditions remains chronic, such that the patient cannot fast either in Ramadan or atone for the must fast at a later time, the patient will continue to give fidya instead of fasting. Okay. So the question then arises, where or how do I calculate the fidya, that monetary compensation? So the fidya, known as a monetary compensation amount, does fluctuate. So you can contact Madrasa Urwa bin Zubair and we'll gladly assist you with the calculation of the fidya amount. You can contact us on our contact number 07 6829 6829 or via email being edmund@mubz.co.za. edmund@mubz.co.za. We at Madrasa Urwa bin Zubair have indeed received acknowledgement from our students who comprise of professionals in different fields, and they are such that they have freed themselves to study deen for the pleasure of Allah subhanahu wa ta'ala. And they have indeed found the pleasure and the sweetness of being part of Madrasa Urwa bin Zubair. Alhamdulillah, we do offer various courses to suit the needs of any person or any professional for that matter, be it on-site as well as online. So kindly visit our website at www.mubz.co.za for further information. Jazakallahu khairan. Wassalamu alaikum wa rahmatullah.
We thank the Madrasa Urwa bin Zubair team and Qari Abdullah Sirat for the enlightening information. Just to repeat, the email address is admin@mubz.co.za. The cell phone number 0768296829. In case anyone wants to contact them for the fidya calculation or any questions relating Masail or anything about the fasting. Also regarding fasting, we should remember the fast of Ashura. It is Thursday, 10th of Muharram, 19 August 2021. Okay, our guest speaker for this evening is Dr. Hoosen Randeree, specialist physician endocrinologist. Okay, brief overview. Graduated in 1982 with MBCHB degree cum laude from the Nelson Mandela School of Medicine in Natal, South Africa. Okay, specialized in internal medicine, achieving the fellowship of the College of Physicians of South Africa in 1988. Thereafter embarked on a career in diabetes and endocrinology, being involved in both undergraduate and postgraduate teaching and research at the Nelson Mandela School of Medicine. Recipient of the Novo Diabetes Award in 1991 and worked under Dr. Ralph DeFronzo at the University of Texas Health Science Center in San Antonio, Texas, in USA. Presented at numerous scientific meetings, both national and international, and has been invited as reviewer for various peer-reviewed journals. Served on the executive committee of the Society of Endocrinology, Metabolism and Diabetes of Southern Africa. Also served on the scientific committee of SEMDSA tasked to draw up guidelines for type 2 diabetes, with special focus on Ramadan and diabetes. Member of several advisory boards, both local and international, in the field of diabetes. And he is currently in private practice at Parklands Medical Center in Durban, South Africa, and continues to be involved as a part-time consultant at the Diabetes Endocrine Unit at the Nkosi Albert Luthuli Hospital. And we would like to request Dr. Sheikh to introduce Dr. Randeree. You're going on shortly.
Jazakallah Ali for those kind words of introduction. Assalamu alaikum to everyone. Good evening. It's my pleasure to present this evening, and I would like to take the opportunity of thanking IMA Highfeld for inviting me to speak, and I wish them all the best in their endeavors to expand their membership and carry on the good work that they're doing in that region. Also to thank Servier Laboratories who are hosting this evening's meeting as well as a sponsor. So, as alluded to earlier, the topic is critical decisions in the modern day management of type 2 diabetes. And whilst I'm not going to only speak about Ramadan, I will certainly touch on aspects of diabetes and Ramadan fasting with the Dia-Ramadan study, and I'm happy to take questions on the subject. These are the disclaimers from the company, and these are my disclosures. Now, I would like to take the audience a little bit a step back and look at the epidemiology of type 2 diabetes, just to get an idea of the scope or the burden of diabetes. As you are aware, there is now a global epidemic of type 2 diabetes. And as you can see from these IDF figures, that in the year 2019, there were 463 million type 2 diabetics worldwide. And it is projected that by the year 2045, that number will reach in excess of 700 million. Now, what's interesting is that every time a prediction of this nature is made, the number is exceeded well before the time arrives for the actual date, so that you will see the number would be much higher even before 2045. The other issue to bear in mind is that this increasing prevalence is not confined only to developed countries, but it is particularly evident even in developing countries, including Africa. And one must bear in mind that these are resource poor countries, and they can ill afford the healthcare spend on diabetes, especially with the rising prevalence of this nature. In some instances, this rise is almost exponential. What about some local figures? If you look at the diabetes report in this country, you can see from these figures here that from the year 2010, in almost a decade, by 2019, there was a threefold increase in the prevalence of diabetes. And of course, in as much as we are able to diagnose diabetes, for every individual that is diagnosed, there remains another one who is actually undiagnosed. By the same token, there's a whole uh, group of patients who are in fact pre-diabetic or have impaired glucose tolerance. And as you know, the rate of progression to type 2 diabetes from those who have impaired glucose tolerance is particularly high in Indian patients in this country. Almost a third will become diabetic in the first year. So if you had to add all of this up, clearly not only is the burden involving those with diagnosed diabetes, but also those who are undiagnosed, and of course those who will potentially become diabetic in the years to follow. And all of this then adds to the mortality attributable to diabetes, particularly in individuals who are in their uh, years of productivity and employment. Now, this audience is well aware of the complications of diabetes, in particular the microvascular complications. And as you know, diabetes and an eye disease is a leading cause of blindness in working age adults. Diabetic nephropathy is a leading cause of end-stage renal failure, and diabetic neuropathy is a leading cause of non-traumatic lower extremity amputation. But we also know that the particular problem in type 2 diabetes is that of macrovascular disease, and this refers to cerebrovascular disease, peripheral vascular disease, and particularly cardiovascular disease, as you know, which is a major cause of morbidity and mortality in type 2 diabetes. So the next question might be, is getting the HbA1c down early and safely a priority in the long-term management of diabetes? And I think I want to share with this audience the concept of the metabolic memory or legacy effect. And what this says is that if in the first few years after the diagnosis of type 2 diabetes, if one is able to control the patient tightly, then this has benefits many years later. And you can see on this panel that those on the with the green sort of circle, which shows that if your HbA1c is between 6.5% to 7%, your mortality, 10-year mortality is much lower than on the upper panel, where you find an individual HbA1c of greater than or equal to 9%, where there's almost a 5-fold increase in mortality. And this was also borne out in other studies like the UK PDS, which showed that if you treated an individual tightly in the first few years, these were newly diagnosed diabetics, and if the patient was in the intensive arm of the study, and after a few years of the study, if you left them to usual care, and then you restudied them some years later, what one found is that whereas in the initial part of the study there was benefit from microvascular complications, but the macrovascular benefit was not statistically significant. If you had to follow these patients up years later, the benefit of early tight glycemic control was seen even in terms of macrovascular benefit. So it pays to get people down to tight control, especially in the earlier years of diabetes. And you can see this again on this graph, where you see individuals who in the first year have HbA1cs as high as 9%, and you see how that compares in terms of both microvascular events, but as well as that macrovascular events, as well as mortality compared to those who have better control. Now, the current treatment of diabetes is not a one-size-fits-all type of approach. This is promulgated by all the major organizations and bodies of diabetes throughout the world, and the ADA-EASD, which combines the European and the American guidelines, and so as well with our local guidelines, speaks of an individualized target. What this means is that if you have a young type 2 diabetic who is newly diagnosed, who has got no major comorbidities or macrovascular disease, who's got a long life expectancy, who is very motivated, maybe exercising regularly, is techno savvy, has got all the apps that can download glucose monitoring, and has got the resources and support to be able to tightly control his or her diabetes, and in whom there are not many other drugs that can contribute to drug interactions or a risk of hypoglycemia, then you can aim as low as 6.5% in that individual. Whereas if you have an older patient who is like about 55 or 60, who now already has comorbidities like some malignancy, or is sitting with other complications of a macrovascular nature, like having had a stroke or a TIA or cardiac stents, etc. And this person is living alone, is not very motivated to tight control. Their resources and support system are not ideal, in that should they then have a problem, they are not able to access assistance. And in particular, this refers to hypoglycemia, because if an individual is living alone and gets hypoglycemic and cannot get third-party assistance, then clearly the idea in these individuals would be to soften the target for HbA1c even between 7.5 and 8%. So this is the individualized approach to the glycemic target in type 2 diabetes. So to summarize these sort of recommendations, our guidelines from the country, the SEMSA guidelines, of course, were last published in 2017 and are due for update this year. But even as far back as that, the individualized target of under 6.5 for the younger, newly diagnosed diabetic with no comorbidities and a long life expectancy, compared to less than 7% for the majority of patients, and a somewhat higher target for the frail patient with comorbidities and a reduced life expectancy. This was already promulgated at that time. So to move on then, what is now new in terms of treatment in type 2 diabetes? As you know, we've seen a flurry of clinical trials that have emerged, particularly with newer agents such as the GLP-1 receptor agonists and Sglt2 inhibitors, and more each week a new product is coming to market with different sort of evidence for benefit. So I just want to walk you very quickly through some of these trials. As you can see on the upper panel here, you see all the GLP-1 receptor agonist trials, and in the lower panel, the SGLT2 trials. And what I want to highlight here is that when the FDA some years ago suggested that in order for a drug to reach market, that it has to show cardiovascular safety, then there was these studies that then had to be done to show that safety. And what emerged, however, was not that it was only safe, but surprisingly, some of these actually showed benefit in terms of cardiovascular disease. We call MACE as major adverse cardiovascular event, which is a composite of cardiovascular death, non-fatal stroke, and non-fatal myocardial infarction. And as you can see, the LEADER study, the SUSTAIN 6, the Harmony, and the REWIND all showed benefit for MACE, which is the primary endpoint, whereas some of them did and others did not show all-cause mortality. Similarly, the benefit is also seen in the SGLT2 receptor, SGLT2 inhibitor studies. Now, this is some of those studies. For example, the leader showing liraglutide benefit, sustain showing semaglutide. And I'm only mentioning sustain also because, as you know, semaglutide is about to be released in this country as a once weekly GLP-1 receptor agonist. Now, important point that we must remember is that when you looked at these studies, if you had to see the benefit, that was seen only in that cohort that had previous cardiovascular disease or evidence of a cardiovascular event. And what came out was that if you did not have those features, then the MACE benefit was not seen. So it's important to bear that in mind whenever we interpret these studies that are reaching our shores. To make the sort of a departure from that fact, the one drug was dulaglutide in the Rewind study. This is now Trulicity once a week, which had only about a third or so of patients who had prior cardiovascular disease. So this was the only one that sort of showed the majority of patients that in fact had only risk factors, but not disease or an event. So you could say that it was more like a primary prevention study, whereas the others were not. And again, you can see that across many endpoints, there was benefit with dulaglutide in the Rewind. And of course, as you know, there was also renal benefit, but some tendency towards worsening of eye disease, which I will come to. But just to bear in mind, in terms of, and to dispense with the eye problem, what has been found in many of these studies is that if the faster or the more rapidly you bring down the HbA1c in poorly controlled patients, in other words, if you do so very rapidly, that acute improvement can in fact worsen retinopathy, but that's been known for many years. So then when we look at other studies in terms of Sglt2 inhibitors, a similar thing emerges, that the benefit was seen in those with established disease and not in those with risk factors only. So the point being made is that for patients that we need to treat come through your doors, bear that in mind in terms of the prescription of the newer agents. Now, for many years, there's been an argument that sulfonylureas are harmful and may cause cardiovascular harm and contribute to mortality. And I must say that this Carolina study did put to a certain extent that concept to bed, because this was a study that compared glimepiride, which is sulfonylurea, to linagliptin, which is a DPP4 inhibitor. It's not available in this country. But as you can see, that for 3-point MACE, there was no worsening with glimepiride. So again, I don't think we should take home the message that sulfonylureas are bad in terms of cardiovascular disease. So as I pointed out earlier, patients that are benefiting from these cardiovascular outcome trials are those with established disease. So what do we do with the large majority of type 2 diabetics that we are looking after? We still have to control the glucose. Glycemic control remains very important throughout the history of a diabetic, but clearly more so before the event. We have to manage cardiovascular risk factors, blood pressure, lipids, etc. And there are many studies that show that if you control glucose and go beyond that glucocentric approach and use control of blood pressure, lipids, stop smoking, reduce weight, exercise, etc., you impact much more than if you had a purely glucocentric approach. And of course, the idea is to prevent the first event rather than to have secondary prevention. And if you look at these studies in the context of the real world, now often clinical trials are very strict in terms of the entry criteria, in terms of what is this kind of supervision that's involved and the monitoring, etc. What has emerged in this study that showed that if you had to look at the percentage of patients who in a real world would be applicable to these studies, you can see that the percentage is not very high, particularly with some of these studies like Sustain, Leader, including Rewind. So applicability in the real world to those large majority of patients who are actually do not have an event or evidence of disease is limited. And the same applies to Sglt2 inhibitors also. As you know, they have shown benefit in certain categories of patients, which I will come to. The other point to bear in mind about glucose control is a lot of recent hype about certain drugs being good in this and that context. But bear in mind that there was this very interesting analysis, and that looked at To what extent did the benefit in these large outcome trials, how much or to what extent could you attribute it to the improvement in glucose? And here's some figures there. Almost half of the benefit in Rewind with dulaglutide or Trulicity, almost a variable proportion with Victoza and Leader. And if you look at a meta-analysis of 12 cardiovascular outcome trials, you can see that a good proportion of the benefit was due to the improvement in glucose. But I don't want you to go away thinking that the newer agents do not have a place. Clearly, we know, and this is internationally accepted, that if you have a type 2 diabetic with established atherosclerotic cardiovascular disease, then your choice of a drug is a GLP-1 receptor agonist with proven cardiovascular benefit or an Sglt2 inhibitor. Whereas if the patient has got diabetic kidney disease or heart failure, then an Sglt2 inhibitor is the treatment of choice to be included in your armamentarium. To summarize then, these two newer classes of agents, the GLP-1 and the Sglt2 have been studied mostly in patients with established cardiovascular disease. Only dulaglutide showed primary benefit. Even Sglt2 inhibitors in their reduction in hospitalization for heart failure has been shown in those with reduced ejection fraction. Having said that, there's some new data where the benefits may be seen also in those with the common variety of heart failure with preserved ejection fraction, for which condition to date there hasn't been very effective therapy or specific therapy other than weight loss and control of high blood pressure and other risk factors. Bear in mind also that you cannot use that or view these new drugs on the market with not taking into consideration that the benefit was seen on the background of these drugs. All these trials had metformin or a sulfonylurea or insulin or a DPP-4 inhibitor as background therapy. So it was on top of these drugs. And of course, I mentioned the cardiovascular data. Now, it is tempting to say on logic that if atherosclerosis is a continuous process, that whatever treatment you use later on in the time course of the disease will also work earlier. And so why wait? And I see this sometimes in certain prescriptions coming to to my attention, where I ask the individual, why are you on this drug? Are you hypertensive? And I'm not hypertensive. I just, my doctor felt that I should just for protection. Why are you on aspirin? No, I just, no, to protect me. Why are you on statin? Just to protect. I think we have to draw the distinction between primary and secondary prevention, because clearly, many of these drugs, including aspirin, do not have a proven benefit in primary prevention and in fact can cause more harm than good. Whereas there are certain specific situations where they certainly will benefit individuals. For example, if you've got diabetic kidney disease, you've got to use an ACE or an ARB. If you've got heart failure or chronic kidney disease, you must use SGLT2. But that's not for primary prevention, that's for secondary prevention. Now, the next question is, what then do we do with the large majority of patients who have type 2 diabetes or don't have vascular disease? And as I pointed out, multiple risk factor intervention is important. And as you can see, that sulfonylureas, particularly gliclazide MR, featured in the 2017 guidelines either as monotherapy, right, if the patient was intolerant to metformin or was contraindicated, but certainly as second line and third line therapy in the treatment algorithm for people without metabolic decompensation or cardiovascular disease. And I doubt whether that is going to change much in the new guidelines, clearly because there isn't any evidence to point for harm from the sulfonylurea group, particularly gliclazide. And you saw that in the guidelines also, if you look at the fine print, the gliclazide MR was the preferred sulfonylurea in the treatment algorithm. Also, to understand that although these are not all head-to-head studies, the kind of HbA1c reduction that you see with sulfonylureas is certainly better than the DPP-4 inhibitors and SGLT2 inhibitors, but certainly the gliclazide in some studies has fared better than the other sulfonylureas. And another argument that keeps coming up is the risk of hypoglycemia with sulfonylureas. And this is a very interesting analysis of 207 studies where the risk of hypoglycemia with gliclazide was of the order of 3.6, and which was not too far away from metformin. As you know, metformin by and large is not a cause on as monotherapy for hypoglycemia. So I think that we have to bear in mind that all of the drugs in a sulfonylurea class are not the same. And certainly the risk with gliclazide is much lower than that we would see with, for example, glibenclamide or any of the other sulfonylureas. And here you can see studies done by some of the workers who have done a lot of work in Ramadan and diabetes, like Hassanein et al., which showed that the risk of hypoglycemia in these studies was similar to that of a DPP-4 inhibitor. So there is an important sort of recognition that we have to have about the intra-class differences. Not all sulfonylureas are equal. And similarly, I don't think not all of any class are equal. Certainly, even within the GLP-1, SGLT2 group of drugs, there are differences in terms of benefit, and we see that in the clinical trial. I just want to remind the audience that the Accord study looked at gliclazide. It wasn't the MR preparation, but clearly in that study, we were able to show lots of benefits, including renal benefit with gliclazide. Now, because there was a mention of Ramadan, I thought I'd just highlight one or two aspects of Dia-Ramadan study, which it was a study that was a real-world study in patients with type 2 diabetes using gliclazide MR, and the inclusion criteria are there and the exclusion on the right side. But just to remind the audience that there was a 3-month period in which they used gliclazide MR before Ramadan, and there was a run-in period of 6 to 8 weeks. They used it in Ramadan for around 4 weeks, and post-Ramadan for 4 to 6 weeks. And what they found is that the average age of these patients is around 54 years. They had about 5 years of diabetes, the HbA1c of 7.5, and they used gliclazide MR alone, and in other situations, they had it with one or more oral agents. And what came out clearly is that severe hypoglycemia, which is what we call hypoglycemia that requires third-party assistance, was absolutely not evident in the study using gliclazide MR. Of course, there were some cases of confirmed hypoglycemia in the period, but you could see that the numbers were really not very high. But what was interesting is that there was a 0.3% reduction in HbA1c. Now, I just want to make a point that in Ramadan, you're not aiming to improve HbA1c. It so happens that in this study, there was the benefit that was seen, but you really want to stay out of trouble. More importantly, you want to maintain your HbA1c. If you improve it, it's good. But what's very important is that in spite of the study showing a greater proportion of patients achieving a lower HbA1c at visit 1, which was early on in the trial, what is important is that the fasting sugar came down by about 0.54 millimoles per liter with gliclazide, compared to the comparator. But what happened there is that there was also some degree of weight benefit. Again, sulfonylurea, including gliclazide MR, is not a weight loss drug. But if it goes in the right direction, if there's weight neutrality or some degree of weight loss, then that's a bonus. And I think what's important is that if you have low rates of symptomatic hypoglycemia and your HbA1c improves, your fasting glucose improves, and you have some weight reduction, then you can safely use gliclazide MR during Ramadan. Of course, there are certain caveats to that in how you're going to change the dose and the timing of the sulfonylurea, which we can have a discussion on during Q&A. So what about some other studies that have looked at in Ramadan, the two drugs, for example, gliclazide compared to vildagliptin, which is Galvus, as you know, or Jalra. And here, you know that DPP-4 inhibitors are considered Ramadan-friendly drugs. But here you can see that under many of the observed parameters, HbA1c, hypoglycemia, both confirmed and severe, and change in body weight, there was no significant difference between the two groups of agents. And in fact, even hypoglycemia episodes were not much, and the weight change was slightly up in terms of gliclazide, but clearly not significant. There's another study that compared gliclazide modified release to another DPP-4 inhibitor, sitagliptin, in a real world, and that's where I think it matters a lot. And the primary outcome was a time to achieve an HbA1c less than 7, and with a couple of secondary outcomes. And as you can see here, that we found the sulfonylurea, gliclazide MR getting to you down in terms of the HbA1c much earlier, and you can see the separation of the curves occurring earlier. And as a result, the HbA1c control was already seen by 3 months. but very importantly, that about a third, almost 35% more likely to reach the target of under 7% with MR gliclazide compared to sitagliptin. The same applied to a HbA1c of less than or equal to 6.5%, which is a lower target. And of course, we always say, how long would people continue? What's the durability and persistence with the drug? A lot of times we prescribe drugs, whether patients take it is another issue. And certainly we found that, as you know, DPP-4 inhibitors are generally very user-friendly drugs, but here also there was a similar durability and persistence. So to summarize that part of the talk, we know that the guidelines in 2017, which are due for update, recommend gliclazide MR as the preferred sulfonylurea. Glycemic efficacy favors the MR versus DPP-4 inhibitors. The potential for severe hypoglycemia is low with gliclazide. Weight gain is not an issue and durability is maintained. Now, just to sort of finish off, one other consideration is renal safety and renal protection. As you know, that in terms of type 2 diabetes, about half of all adults with type 2 diabetes have diabetic kidney disease. And about a third of them have disease involving the kidney even before their diagnosis because they have been undiagnosed. And in many countries, the incidence of end-stage kidney disease due to diabetes has risen much faster than the overall end-stage renal disease incidence. In other words, diabetes seems to be leading the pack there. What we know, however, is if your type 2 diabetic patient has got kidney disease, then they are automatically at high risk for many events, including and in particular myocardial infarction, heart failure, stroke, infections, amputations, hospital admissions, and mortality. So it is a poor prognostic marker in a type 2 diabetic patient. We know that once you get diabetic kidney disease, both morbidity and mortality increases. And I mentioned all those sort of morbidities that can occur, and they are listed in the lower panel. Now, one of the studies that looked at gliclazide versus glimepiride in the reduction in end-stage renal disease with the similar glucose lowering did favor gliclazide over glimepiride. There have been other studies as well showing, like as I told you, in accord with glimepiride, with gliclazide, that there was benefit in terms of renal outcome. Also, I pointed earlier to that metabolic memory or legacy effect, and that is also seen in terms of renal outcome. So it pays to get control early on in the course of a type 2 diabetic. You see the downstream benefits. So the double challenge is that in terms of, on the one hand, renal safety, because in patients with diabetic kidney disease, you got to use drugs that are appropriate as anti-hyperglycemic agents, but they need to be safe. But you also have to protect the kidney because that is a very important aspect. And I'm talking about renal protection over and above your conventional glucose control, blood pressure control with an ACE or an ARB, and statin therapy, etc. So we're talking about renal protection in that context. So just to give you a sort of a comparison, if you compare the sulfonylurea group, like I mentioned, the advanced study using gliclazide and DPP-4 inhibitors. DPP-4 inhibitors do not have any renal or cardiac or heart failure benefit. They are safe drugs to use, but they haven't been shown to have benefit. Some of them do have some trend, but these were non-significant in the trials, except, of course, there was a Carmelina trial with linagliptin, which is not available, which showed some renal benefit. Whereas when it came to, as I say, the sulfonylurea group in advance, you could see many of the endpoints were benefited. Now, I want to highlight the upper part of that green panel, where, as I alluded to earlier, we are talking also about primary prevention. In other words, person does not have any kidney disease. And here you could see some benefit in new onset microalbuminuria. Of course, once the person has got established kidney disease, then I bring into your focus a lot of the evidence in the group of drugs, the Sglt2 inhibitors. And you can see in EMPA-REG, in CANVAS, Credence, DECLARE, as well as in other renal outcome trials like EMPA-REG, Renal, we have DAPA-CKD, a lot of other dedicated renal outcome trials which have shown the benefit of Sglt2 inhibitors in the context of renal disease with albuminuria, by the way, but even in those who are not diabetic. So I think the distinction between primary and secondary prevention needs to be borne in mind. Of course, you must bear in mind that these drugs are just not all to be used all the time. Under EGFR of 30, you cannot use gliclazide, but glibenclamide and glimepiride are clearly contraindicated at even higher levels of EGFR. And so too with some of the DPP4 inhibitors. To summarize the kidney disease aspect, we know that kidney disease or diabetic kidney disease is a huge burden in type 2 diabetics. We know that we have to use renal safe and renal protective treatment. I told you about DPP4 inhibitors and Sglt2 and how they differ, but I want to highlight for you that the benefits with Sglt2 is in albuminuric diabetic kidneys. It's not in those without albuminuria. Okay, and when you prescribe drugs, you've got to look at dose adjustments in the context of renal disease, and current renal outcome trial results cannot be extrapolated to all type 2 diabetics, but clearly we need to bear in mind where there's a compelling indication for certain classes of drugs. So my conclusion for this evening is to say to you that we should not be throwing out some of the established drugs such as the sulfonylureas, in particular gliclazide MR. I mentioned that because of its benefit. They remain the cornerstone of therapy in type 2 diabetes because we've had many years of experience. Most of us have grown up at medical school and postgraduate with the use of these drugs, and we have experience with them. They are certainly highly efficacious. They are generally safe and affordable, especially in developing countries. The complications that have been spoken about hypoglycemia, although not that it is not existent, but it's relatively low, and so is weight gain. And I think we need to bear in mind that when we interpret all these newer drugs that are being put out there in the market, especially the GLP-1 receptor agonists and the Sglt2 inhibitors, bear in mind that you cannot throw out the SUs because many of these studies had SUs as background therapy in these studies. So you can't discount them. It was on top of SUs. And the benefit, as I showed you earlier, was that you have to have established disease or albuminuria or heart failure, and you cannot extrapolate benefits in primary prevention. And I think I've shown you at least some evidence today that gliclazide MR has been shown to be safe for use in Ramadan, as is with the DPP4 inhibitors as well, who are relatively Ramadan-friendly drugs. So with those words, I thank you for your attention.
For a very informative talk. We have our first question for the evening. The first question is, I have a patient with glucophage XR1G.
Ali, I think your volume is quite, I'm not able to hear you, sorry.
Can you hear me now? Is it clearer?
Just faintly, but I'll try and listen. Thank you.
Can you hear me now?
Dr. Randeree, I think it's probably best for you to address the questions in the chat. I think there's something wrong with Ali's mic. Can you access the chats?
Okay, so I can access it. The first one is, you have a patient with glucophage XR 1 gram BD and diaglycide MR 60 in the morning. How do we alter dosage timing during Ramadan? Hemoglobin A1C is under 6.5. Okay, that's a very interesting question. What you're seeing is, remember that you have to, there's a whole risk stratification in terms of diabetics into who should be allowed to fast or who should not fast or must not fast. But those sort of risk stratification scores aside, if it's a general question, then what I'm saying to you here is the recommendation is that you leave the glucophage XR in the morning and evening because it's a drug with low hypoglycemic potential. And you take the diaglycide MR that you're taking in the morning and you take it in iftar time. Generally, the rule in Ramadan is take the higher dose and take it with iftar and take the lower dose with suhoor. So for example, if this patient was on 60 milligrams in the morning and 30 in the evening, you would switch it around to 30 in the morning and 60 in the evening. Let me just see if I can go higher up to the next question. I don't know, Ali, if you can see the next one, but I'll take the next one. Steroid usage. In COVID patients, diabetics on oral agents only, advised to GP how to add drugs like Novorapid long-acting insulin to control sugar water. So it is a very important question because, as you know, with COVID and particularly with high-dose steroids used in a home setting and as part of COVID home care, a lot of these can produce enormously high levels of blood sugar. Now, if the patient is already on suboptimal oral therapy, for example, on low-dose sulfonylurea, you can attempt to increase the dose of the sulfonylurea, add a metformin. I certainly wouldn't look at adding some drug like an Sglt2 inhibitor because, as you know, in a catabolic state, you can get DKA occurring. So then we have to resort to insulin. Now you have two options there. You could leave the individual on their background therapy, or if they adjusted background therapy, and use short-acting insulin, whether it's Novorapid, whether it's Epidra, whether it's Humalog, and you can do corrective doses based on a sliding scale, for example, at breakfast, lunch, supper, and bedtime. But if you're really having more difficulty than that, and often the glucose levels can go as high as almost 25 and 30 and even higher, then I think the basal bolus, which you allude to, is very important because here you then work out and you give the patient a Novorapid 3 times a day with a bedtime insulin. As I say, you could use Novorapid or any other short-acting insulin with a long-acting insulin at bedtime. The challenge you have is with these steroids that the rise in blood sugar is not predictable. You often, if you took a steroid dose like prednisone in the morning or Medrol in the morning, you'll find that your spikes in sugar occur in the afternoon and early evening. So you have to be careful that you don't give an equivalent dose throughout the meals, and maybe you have to give a higher dose at lunch and supper. And you often find that if you've given a single daily dose, by the next morning, the glucose has settled. So that is the basal bolus regimen, which is most effective in controlling patients with COVID on steroids. Of course, in the hospital environment, if the sugars are very high, we start an insulin infusion. The next question is, would one use Sglt2 in Ramadan in view of increased hydration necessary? Okay, that's a very interesting question. There's also a second part to it, that what EGFR would you stop as? Firstly, as you know, that drugs like empagliflozin have been approved down to an EGFR of around 30. So you wouldn't start it between 30 and 45, but it can, your GFR can, in fact, it can be used until a GFR is up to down to about 30. Now, one thing to remember about GLP-1 receptor and SGLT2 receptor, SGLT2 inhibitors and GLP-1 receptor agonists, is that you should start the drug, if you want to use it, at least about a month or so before Ramadan, because you got to allow the person, in the case of GLP-1 receptor agonists, to acclimatize themselves to the gastrointestinal side effects. With SGLT2, similar. You want to be able to use it and the person to acclimatize themselves. The question about hydration, there have been studies now that have been done, particularly in warm and humid climates like the Middle East, on SGLT2 inhibitors, where the safety of these drugs have been established, even in those areas where there's like a hot climate and you find that you have to fast for long periods in the summer months. And the idea then is two things. One, you take your SGLT2 inhibitor in the evening rather than the morning. And secondly, in the non-fasting period, you ensure that you adequately hydrate yourself. As you know, it's been become a bit of a norm now in many masajid for people to carry a water bottle in between segments of Taraweeh, etc. So you gradually hydrate yourself in the non-fasting period. Next question, please. Can you comment on new onset diabetes post-COVID? Very interesting question. Many theories exist about this. The one theory that links directly to the fact that the virus actually attacks the beta cells and the ACE receptors there brings on the entity of what we call new onset diabetes. Okay, that's the one entity. The other situation is that at least we've seen some patients who may show hypoglycemia during COVID, but have been undiagnosed. Because you can easily check these people out. Because you do HbA1c on presentation to sugar, you will find that the HbA1c is high. That must mean that they have been diabetic before their COVID infection. And the last entity is, of course, when you put them on steroids, you bring on diabetes. So these are all the scenarios that you face with. I must say to you, you should be patient. If you have got HbA1c that's high, then you know post-COVID, after steroids, you'll have to plan their diabetic treatment. The new onset, you'll do similar, but the steroid-induced ones, often you are able to see as you de-escalate therapy and you stop the steroids over several weeks, you'll be able to determine whether there's a need for ongoing therapy. And perhaps at about 3 months post the COVID infection, you can analyze an HbA1c and or GTT to determine whether they are still diabetic. Opinion on low-dose metformin in normoglycemic patients as preventative in patients with PCOS and cognitive protection patient. All right, so these are interesting questions. I must say that in terms of PCOS, as you know, the glucophage or metformin is a recognized treatment. Now, I want to warn and caution the audience about what I see as these preventative drugs, sort of doses. You know, in the PCOS studies, the amount of metformin that was used for benefit was in the order of almost 850 milligrams twice a day or more. So that we often find people using homeopathic doses of metformin like 500 once a day, hoping to alter the clinical course of PCOS. You got to use, provided tolerable, you got to use an appropriate dose in PCOS, as long as I say they don't have side effects. As regards prevention, now we would not use it, we use it for PCOS, but if the patient in addition has got impaired glucose tolerance, again, they also, you must give an appropriate dose, other than, of course, lifestyle, weight loss, and exercise. You can combine it with metformin to prevent the progression from pre-diabetes to diabetes. As far as cognitive protection in patients with dementia, there have been some studies, and I must say to you, like there are studies with metformin, even in cancer patients, in cardiovascular disease, I think there the jury is not out. And I wouldn't particularly use metformin as a drug to prevent dementia. If the patient is on metformin, it's fine, but I don't think it has established its role in those type of prophylactic and protective scenarios. The place of Trulicity for weight loss in PCOS, important question. As you know, the doses of the doses of Trulicity that are available in this country at the moment are indicated for diabetic purposes. That's the 1.5 milligram. You see some improvement in weight with it, but I must say that I've seen more impressive weight loss with the semaglutide, which is being launched shortly in this country. That's your what you call new GLP-1 receptor semaglutide. Having said that, in other parts of the world, there are higher doses of Trulicity, like 3 and 4.5 milligram, which are being registered purely for weight loss. And of course, they will benefit those patients with PCOS. And there are studies in PCOS as well, but those results are not yet released. Does metformin have cardioprotective function? Well, there is some evidence to say that it does. Like I said earlier, like in cancer, etc., there have been studies that have looked at the benefit, and they looked at metformin and non-metformin users, and they found that a subset of them who were on metformin or that category had better outcomes. I wouldn't use the drug for its cardioprotective benefit. I would use it as its indications are established in diabetes and in other conditions. But I'm then saying to you that if it, and you must take comfort in the fact that, you know, especially in diabetes, it forms the cornerstone or the backbone of therapy. It's the primary drug you're going to use. So no problem, it's there already on board, but I won't prescribe it for its cardioprotective function because, as I pointed out earlier to you, the GLP-1 receptor agonists are really the drugs of choice for cardiovascular disease. What GFR would you stop metformin? Also a very interesting question, because as you know, when your EGFR goes down between 30 and 45, you must reduce the total dose of metformin to 1 gram a day. And below a EGFR of 30, you should stop metformin. Having said that, there have been many trials where metformin was used down to a lower EGFR and nothing happened. Clearly, the worry you have is that of lactic acidosis. And I must say, I have not seen a case due to metformin of lactic acidosis. Having said that, from a medical legal perspective, I would recommend that you use those guidelines that I've told you, 30 to 45, lower the dose to a gram maximum a day, and below 30, you should stop the metformin. Are there any other questions?
Doctor.
Dr. Randeree, there was a question on, please comment on the impact of non-nutritive sweetness in diabetic control.
Okay, so I know this is now goes like a yo-yo, and you can read an article today that speaks about its benefit and others say not. I must say that the last that I came across any substantive literature on this is that not only did it really make no real difference in that, but it's also these compounds have been associated with a variety of non-specific symptoms and side effects. So in my own sort of practice, and I'm guided a lot by the dietitians, and maybe there's a dietitian on the panel that'd like to comment, but I say to individuals either no sugar, but if you had to add a little bit of ordinary sugar, it makes no difference, because I haven't seen evidence about the benefit of these, and they are rather expensive, as you know.
I know you answered the question on Trulicity with the PCOs, but there's one here. Who will be the ideal candidate for Trulicity?
So as I said to you earlier, as a drug in terms of diabetes control, if you have a patient with diabetes with established cardiovascular disease, and perhaps this is a nice point for me to emphasize this fact. Many a patient would have seen their cardiologist, etc., and would have come back and came to you for control. Now, bear in mind that, these drugs are not cheap. But having said, and cost were not an issue, the compelling indication for a GLP-1 receptor agonist, whether it be Trulicity or otherwise, is a person who has got any evidence of cardiovascular disease or has had a cardiovascular event. So you got to ask yourself, when a patient comes to the door, my patient saw a cardiologist, just had a stent put in, has had an infarct, should I not be giving this patient for its cardio protection a drug like Trulicity or any other GLP-1 receptor agonist? The same applies to Sglt2 inhibitors, I pointed out earlier. If your patient has come out of heart failure treatment and is come back home having been admitted with heart failure and is already on a beta blocker, on spironolactone, on an ACE or an ARB or an ANI, you got to ask yourself, why is my patient not on a Sglt2 inhibitor? Because those are the compelling indications. And as you know, in the first month or year after heart failure admission, you often find there's a readmission, and there's also mortality is very high after one admission for heart failure. So I think you as the general practitioner also should be aware of affording your patients the benefit of these newer drugs in the correct clinical context.
I think we've actually answered all the questions, unless there's any more questions in the chat, or if anyone wants to unmute themselves to ask any questions.
Ramida, can you hear me? Hello, can you hear me?
Just faintly, I just try and ask your question, maybe I'll be able to hear. Fatima, are you able to hear the question? Perhaps you can repeat it for me.
I don't think there's any more questions. I'm not sure what's wrong with Ali's mic. Ali, do you want to try once more?
Sure, Ramida, can you hear now? Is it coming through?
Try and increase your volume on your computer, Ali, or the device that you're using.
The volume is on full. I don't know what's happening to the signal.
Sorry, Dr. Randy, there's one more question.
G. Well, I think it refers to low carbohydrate.
Yes.
Yeah, I must say to you that in my experience, of course, it's come up and to vogue recently, but I must say that I have found that not everyone responds. There are those that respond to this low carbohydrate and others don't. So that's an individual difference. Having said that, I often have used it not as a long-term management, but basically to kickstart a kind of weight loss program, and after which the patients are able to then maintain it. I find that persistence or adherence to this lifestyle is not everyone's cup of tea, and many people, after a few weeks or months, they deteriorate back to their usual lifestyle. So I must say to you, they are individual responders, and where it does work, it works beautifully. There's a nice question here coming up asking, would a patient with predominantly postprandial hyperglycemia benefit from a gel more than an insulin therapy? That's a very important question, because as you know, that generally in terms of the first injectable after oral treatment failure in diabetes, it has always been said that we should use basal insulin as the first sort of insulin or injectable. You know, basal insulin only is able to control the fasting sugar. And the GLP-1 receptor agonist, yes, by its very mechanism of action, is more beneficial towards postprandial hyperglycemia. So it's not a bad idea to use both of them. And it's for that reason, as you know, that we have on the market at least two agents which are a combination of a GLP-1 receptor agonist and a basal insulin, affording the protection or the benefit of both fasting as well as postprandial hyperglycemia.
Okay, I think that's fine. Shukran, Dr. Randeree. I'm just trying to see if Ali is able to actually sort out his mic. Otherwise, I'll get Dr. Wadi to actually complete the program.
Jazakallah to everyone.
Okay, I'm just waiting for Dr. Wadi to come on to close the program. In terms of the CPD, this will be generated automatically to all those on the program, those that have attended. And Kashifa will actually be in touch with you with regard to this.
Assalamu alaikum wa rahmatullahi wa barakatuh. Femida, can you hear me?
Yes, Dr. Wadi, I can.
I think because Ali's mic is not working, it falls to me to do the vote of thanks and also to wrap up the meeting. So I think it's really been an excellent presentation. And first of all, we'd like to thank Dr. Randeree. Jazakallah khair. May Allah reward you for taking out the time and putting through the effort. And inshallah, the information that you have given us will be of benefit to many, many patients and will multiply as the many practitioners make use of it. Secondly, we'd like to thank Servier once more, as you mentioned, by coming forward to sponsor this meeting. Whatever funds we get from these organizations obviously help us to procure the speakers, but also go towards funding the branch activities of the various branches around the country for the organization. We also encourage all of you who are attending and who are not yet members to become members. Remember, the organization has a lot of projects, and all the funding we get for projects goes directly into the projects. Not a cent of the funding is taken to run the branch offices, to run the infrastructure of the organization. So we really need your membership fees to help us to do that. And some of your membership fees also goes towards the project. So we lost our ability to have a convention this year, which was a major income stream for the organization. So we pray that, inshallah, those of you who are dithering or haven't joined yet or haven't paid your membership fees can please contact Kashifa or Tohida or Shireen or one of the officers and try and help us to keep the organization going. We make dua that Allah subhanahu wa ta'ala takes our country and the world out of the current situation that we find ourselves in, and gives relief to all those around the world who are suffering, whether it be with diabetes, whether it be with COVID, whether it be with any other condition. We know there's a lot of suffering and difficulty and hurt. Our country is seeing problems with poverty, with political instability, with COVID, on top of all the previous problems that we've had already. And there are many places in the world where humanity is suffering. And I don't need to name them. Most of you know them very, very well. So we make dua that Allah subhanahu wa ta'ala gives people all over the world relief. With that, we will wrap up the meeting with a recitation of Surah Al-Asr. Bismillah ar-Rahman ar-Rahim. وَالْعَصْرِ إِنَّ الْإِنسَانَ لَفِي خُسْرٍ إِلَّا الَّذِينَ آمَنُوا وَعَمِلُوا الصَّالِحَاتِ وَتَوَاصَوْا بِالْحَقِّ وَتَوَاصَوْا بِالصَّبْرِ. Jazakallah khair, and thank you once more for attending, and also to Femida for being our kind and very able host today.